There we go. All right, I'm going to start. My name is Anne. For those of you who don't know me, I'm the editor of Airway Circle, and I'm happy to welcome Dr. Robert Lynn to Thursday Night Live. Dr. Lynn, can I introduce you and then we'll get started? I know we have a little bit of a late start. I apologize, everybody, but this is being recorded. For those who missed it, we are just getting started. So I'm going to properly introduce you. Dr. Robert Lynn graduated from the University of Queensland in Australia in 2009. After spending the first few years practicing general dentistry, he started practicing orthodontics in 2013. His mentors include Dr. Kenneth Lee and Dr. Mahony, who are among the top 100 doctors in the world. In 2018, Dr. Lynn achieved his fellowship with the International Association for Orthodontics and began teaching at the International Academy of Advanced Dentistry in Sydney. In 2022, Dr. Lynn completed his master's in orthodontics and dentofacial orthopedics at Universitat Jaume I in Spain in 2022. Since 2018, Dr. Lynn has been exclusively practicing with a focus on airway and sleep dentistry, TMD, dentofacial orthopedics, and orthodontics. Tonight's topic is connecting the dots, how airway, sleep, dentofacial orthopedics, and orthodontics are related. Welcome, Dr. Lynn. We are happy to have you. If you'd like to share your screen, you should have access.
Okay, this one. Okay, everyone can see that?
Yep, and I'm just going to ask everyone to please just turn off your video and audio if possible so we can have the best quality on the recording. You're not on a slide, the presentation for the slides. So I don't know if you want to do that or now we see your presenter screen.
Oh, the presenter screen. I'll get rid of that.
Okay. If you go on top where it says, I think it's where it says display settings, one over to the left. There should be a way to reverse it. Sorry, go ahead. Go again to start slideshow.
Yep.
You can do it from here. We don't mind, but if you go to slideshow all the way on top.
I'm just going to get rid of this bar. Which one do I go?
So when you go to display settings, do you see that's, click on that for a second.
Is this one?
No, not that one. Okay, go, there should be, oh no, I'm sorry. Yes, the top one, swap presenter view and slideshow.
Is that good?
Yeah, that's perfect. You're all set.
Oh, awesome. Okay. Oh, thanks for the introduction. So as you can probably tell, I'm from Australia, so I'm sure you've had some Australian speakers before, so hopefully you can understand my accent. Also, apologies for my slightly croaky voice. I've been a bit run down lately with lots of events, so okay. So connecting the dots. This is a topic I came up with last year, actually. The reason being, I started my orthodontics journey in 2013. So for the first 3 years, I learned from 3 different world-class mentors. As you mentioned, a couple of them are Dr. Kenneth Lee and Dr. Mahony, both world top 100 doctors. But the issue I had was these courses. So you go like multiple weekends a year, and then they have like a specific topic every weekend. However, which is very good, but until I started practicing orthodontics myself, I struggled to connect how everything was related together. So like with airway, with sleep, with TMD, with dentofacial orthopedics and orthodontics. So there's a saying out there that knowledge is learning, but doing is understanding. So you got to actually really get into it practically and do it in your offices to really understand it. So it actually took me 2 or 3 years to really understand how everything works together. Plus, going through my own personal journey really helped solidify things for me. So I titled it Connecting the Dots, and I will be talking about my own personal journey as part of this lecture as well. So you've already done a brief intro there. So I won't really go through this. I do have a fellowship with the International Association for Orthodontics. I got that in 2018. And then, I completed my master's degree last year. There's my website there if anyone wants to read more about what I do and learn more information. Outside of dentistry, what I like to do is I'm a big fan of basketball. The World Cup's on right now in Asia. On the weekends, I do a bit of coaching. I run competitions. I run a competition every Sunday. So we have over 40 teams competing in our competition. I do some coaching. I coach the young players as well. I've played with three players in the current Australian team, so pretty high level back in the days before I decided to focus on dentistry. I do, besides dental conferences, I also enjoy personal development and business conferences, and some of the time I get to meet some celebrities. So yeah, just a few examples there. You might recognize a few of these faces. The Kiyosaki's, Rich Dad, Poor Dad. Gary Vee just had an Australian tour a few weeks ago. I was actually invited to be part of his crew for that tour. So that was pretty cool. There's Apple co-founder Steve Wozniak and Dr. Phil. Okay, now the outline of the lecture. Strong focus on obstructive sleep apnea. So in short terms, we just call it OSA. So sleep apnea, there's mild, moderate, and severe. We'll talk more about it shortly. Quick treatment overview, and then we'll also go deep into my personal treatment journey, and I'll help you guys connect the dots on how everything's related together. There'll be some time for Q&As at the end, and the last 3 slides are full of references. I think there's over 40 references for this lecture. Okay, so this is what happened. This is 2012, so this is before I even knew I had sleep apnea. So growing up, even though I was a high-level athlete, I knew something wasn't quite right because no matter how hard I trained, I always lacked fitness. So I was good at like sprinting, but not good at long distance. So I saw many doctors and specialists growing up in Australia, but no one could tell me what was wrong with me. So it was actually my main dental mentor, Dr. Kenneth Lee, in 2013, that pretty much when he met me, he pretty much told me everything that was wrong with me. So that really got me curious on a journey of nonstop learning on like, why can a dentist pick up all these issues when all the doctors I've seen in my life never knew. So I was coming back from a course. It was late at night. I was driving home from the airport. It's about 11 o'clock at night. And then, yeah, I got off the highway, stopped at an intersection behind a bus. That was the last thing I remember. And the next thing is just like literally, boom, I just crashed into a bus stop. And then when I looked on Google Maps, I actually drove 450 meters. So that's about just over a quarter of a mile asleep behind the wheel. So that was pretty scary. Luckily, it was just a bus stop in my car that was damaged. No one was hurt. Yeah, so yeah, I'm lucky to be alive. So so since then, yeah, I've been looking for answers, and then luckily I did find my answers through my mentor. And yeah, I've been that's why I went through my treatment journey, and then I've been helping patients and teaching other health professionals ever since. So yeah, so a bit about OSA and motor vehicle accidents. So people with OSA are 2.5 more times to be the driver in a motor vehicle accident. Also, you're at high risk if you sleep for less than 5 hours, if you have daytime sleepiness, which is obviously a symptom of sleep apnea, and also if you use sleeping pills, because that actually affects your sleep cycles. Another article there shows your accident risk is increased by 2.4 times. And another huge study, almost 900,000 people there, showed that if you have OSA, there's a 17% risk, greater risk you'll be in a motor vehicle accident. And another one there saying it's 2.52 times the risk. So pretty similar numbers there. Just a brief slide about how to assess airway. I know you guys are the Airway circle, so you guys are all into probably already know all about this, but this is how I do it in my clinic. So CBCTs, I've been using these. I operate out of 2 different clinics. I've had CBCTs in there since 2015. So I take a full field of view one, the big one, 20 by 20, like an ICAT, and I always send it to a oral maxillofacial radiologist for a report, just in case I miss anything, and also because for medical legal reasons as well, just to cover myself. I can also use that to obviously convert it to OPGs, LATCEF, PA-CEFs. So I can do my orthodontic CEF tracings on there as well. I also like to measure the airway volumes, in particular the oropharyngeal MCA, which is the minimum cross-sectional area. Now, looking at the nose, when I lay a patient down, I always look into their nose. I look at the turbinates, which is the soft tissue inside the nose, see if there's any swelling, redness. looking at the septum, signs for deviated septum, and nasal valve collapse. That's an important one, especially for people who have a condition we call upper airway resistance syndrome. So if they have airway collapse, when they have a deep breath in through their nose, what happens is instead of their nostrils going outwards, they actually cave in. So that's nasal valve collapse. Checking the sinuses, 4 different sinuses. We check that on the CVCT. Same with the adenoids. Tonsils, you can look at in your mouth. So the grading system is 1, 2, 3, and 4. With so you can see in the image there, grade 1 is when the tonsils are very minimal to up to 25% blockage. Grade 2 is 25 to 50% blockage. Grade 3 is 50 to 75% blockage, and grade 4 is 75% and above. In fact, you'll see later in the photos, my tonsils actually touched in the middle. They were like 2 big golf balls. So they were grade 4. Malempati. Malempati is a classification of oropharyngeal airway space. Again, you can have a look inside the patient's mouth and determine this. Malempati was actually an anaesthetist. So he came up with this classification on how easy or difficult a patient was to put those tubes down their throat for when he had to put them under. So there's 4 classifications there, as you can see, class 1, 2, 3, and 4 as well, with 4 not being able to see the soft palate at all. So in class 1 there is like, you could pretty much see, everything right down the throat. There's also a Friedman classification, which is very similar. The only difference between Malempati and Friedman is one is done with the tongue inside the mouth and one is done with the tongue sticking out, like, and they go, ah, and you look at the back of the throat. And if you suspect any signs of breathing or sleep disorder breathing issues, so make sure you refer to an ENT. It's important to know that not all ENTs are the same, just like not all doctors, not all dentists, not all health professionals are the same. Something that really annoys me in Australia, I don't know if it happens over to you guys as well in America, is that I see some GPs, some doctors doing the right thing. They suspect an airway problem and then they send the patient off to an ENT. And I always ask this question. I was like, okay, what's the reason for? What's the ENT's name? And what did they find? What did they recommend? Because quite a lot of the time, in fact, most of the time, I think, say the patient has a breathing and sleep problem, but the doctors actually refer them to an ENT that may specializes in ears or maybe the throat. So they're not sending the patient to the right ENT. So that's a really important thing to get right as well. Otherwise, they're not getting the right, treatment recommendations.
We run into issues with the ENTs too here, so I think it's across the globe.
Yeah. Okay.
Yeah.
So these pictures here, this is from the AAO white paper in 2019, which I'll talk a little bit more about later, because that was a groundbreaking article that they wrote. That's me. So sleep studies. So that's one way to determine if a patient has OSA. Obviously, OSA is just one sleep condition. There's like over 80 sleep conditions out there. So the only way to really diagnose properly what sleep condition the patient has is to go through a sleep study. This may be different in America, but in Australia, we have 4 levels of sleep study machines. Level 1 is where they go into a hospital or sleep clinic. So there's actually cameras watching the patient the whole night and a person watching them as well. So if they toss and turn, one of the cords comes loose, the technician can put it back on. Level 2 is actually the one I get my patients to do, the one I prefer. I've done 6 of these myself. The reason being, this is a take-home kit. Just my personal thinking is that if a patient is sleeping in their own bedroom, in their own natural environment, I think it's a more accurate replica of their normal night's sleep. For me personally, if you put me into a hospital or a sleep clinic, I would be very uncomfortable. Firstly, with the type of bed, the size of the bed, because I'm quite tall. Even little things like the pillows, the firmness of the mattress, and the noises or whatever, everything. I'm a very sensitive sleeper, so that matters to me. So type 2 sleep studies, you can still diagnose sleep conditions with that. There's enough cords there, enough data, especially looking at breathing, oxygen, heart rate, brain, and muscle activity. Now, level 3 and level 4 sleep study machines, it doesn't provide enough data to diagnose sleep conditions. However, it doesn't mean like, they're no good and you shouldn't have them. I find these devices are really good, like either screening devices or monitoring devices. So for example, screening device, if you're not so sure and you happen to have one of these in your clinic, or if like in Australia, there's a lot of GPs that like I don't know what the right word is, maybe stubborn. They just won't refer the patients off for a sleep test. And maybe if you had one of these level 3 or level 4 devices, you get the patient to do, take the machine home, do a test, and then that gives you some data to show the doctor that, yeah, there really is something wrong. So it'll help maybe push them to refer the patient to see a sleep specialist and get a proper test done. Also, if you're treating the patient for sleep disorder breathing, you can send these home. So you can test the patient before and after, like say you're making a mandibular advancement splint for a sleep apnea. So obviously the patient's been diagnosed, they've had the sleep study, but you can send the patient home with one of the level 3 or 4 devices to compare. So you have an idea that your appliance is working. Sleep questionnaires. There's a lot of different sleep questionnaires out there. We use these to help screen for sleep disorder breathing. The common ones I use are Epworth, Berlin, and Stop Bang. There's also one for kids. So there's so if you have a child in the clinic, make sure you use the pediatric sleep questionnaire. So that's what they look like. They're pretty simple. Just a few questions. They can be filled out very, very quickly. So you can get, the parent can do that while the patient's in the chair while you examine them, or in the waiting room. So, yeah. And that's the pediatric sleep questionnaire. On the right there is a sleep study referral. In Australia, how it works is the patient can get bulk billed sleep studies if the doctor signs off on it. So I've got one of these forms. I get the patient to fill out the questionnaire. So on this form, you've got the Epworth, the OSA 50, and the Stop Bang questionnaires. And to be eligible for bulk billing, they have to meet certain requirements. So I sign off on it, and then I get the patient to bring that to their doctor. And if the doctor signs off on it, then they can get a bulk billed sleep study. So I'm not sure if it's the same in America, but what's going on here in Australia is the government's realizing that more and more people, probably the aging population and obesity, more and more people are having sleep apnea. So more and more people are getting tested. So in a way to save money, now in Australia, we can only have one bulk bill test every 3 years. Whereas back in the day, when I first started treating patients for sleep apnea, they could have one a year. So yeah, the government sort of made it a bit more difficult. Okay. The white paper, so the American Association for Orthodontists, 2019 wrote this 53-page white paper, a very good read. I think any dental health professional could probably read through that and understand it. The reason this is important is because, well, you guys in America are ahead of us because this was released in 2019. Us in Australia, we still, I think 80, 90% of us who practice orthodontics still don't really take Airway seriously, which is unfortunate. But the recommendations from that white paper is that all orthodontists should consider incorporating OSA screening into their history taking and examining of patients. And they strongly recommend a referral as well, in particular to sleep physicians. This is the summary, the 10 main points. So they strongly recommend orthodontists to be familiar with the signs and symptoms of OSA and screening their patients. Point number 9 is a good one there. Some forms of orthodontic treatment have been shown to be important in the treatment of OSA. Now, I'll give you an example. Say if me personally, obviously I practice airway and functional orthodontics. I think about 97, 98% of my patients, I would be actually expanding their jaws at any age. This is talking about the maxilla, not the mandible, because you can't expand the mandible at a certain age without surgery. But because the maxilla is connected to the nasal septum, the sinuses, so over 80% of your upper airway is made up of that maxilla. So as we expand the maxilla, the airway actually gets bigger. So breathing gets better and sleeping should get better as well, in theory, right? So I guess that's what that point means there. And also an interdisciplinary treatment for OSA helps best serve in the best interest of the patient. That's an obvious one there. So it's not a one-man show. Not one person can fix everything. In fact, I work with a team of at least 8 different health professionals in treating patients with airway and sleep issues. Okay, now into the nitty-gritty stuff. These are all pretty much, from research papers. So I'm going to move this away a bit. Oh, there we go. Okay. So risk factors, obviously older age. So let me move this, sorry. So prevalence of OSA increases from young adulthood through to the 6th and 7th decade. Obviously, that's because, as we get older, we tend to put on more weight. We also lose muscle tone. That's a key one. So the airway, the muscles that line the airway, they tend to collapse more when we're sleeping as we get older. So that increases the risk of sleep apnea. Being male also puts you 2 to 3 times more at risk. The reason for this is as males, we tend to put on weight, fat in particular, on our stomach and around our throat region. So what this means is, and also we're twice as bad when we lie on our back. I don't know if you notice, if you know someone that snores, when they're lying on their back, their snoring seems to be a lot worse. So when we're lying on our back, obviously the weight on our stomach is pushing down, making it harder to breathe. And because if we have more fat here as men, it makes the airway smaller. So you're kind of self-suffocating there. So, and that's different to females. Females tend to pack weight and store fat in different areas. So that's why men are at higher risk. And then I just spoke about weight, obesity. So yeah, it's related to BMI. As you can see there, 63% of men who are obese had sleep apnea and 22% of women. Craniofacial and upper airway abnormalities. This is an important one to know because your race, your genetics, it plays a role. In particular with Asians. So I'm Asian, also with Indian background. Whether we like it or not, it's just the way we are. Asians, we're smaller in stature, in structure, smaller airways naturally more mid-face deficient. Our airways are not as good, and we're more prone to allergies, in particular things like dairy. So being Asian puts you kind of behind the 8 ball there. Let's go for an example with sports. Like Asians tend to be good at particular sports, not the sports where you need to be tall, strong, athletic. Because Asians we're actually genetically inferior physically. So we're at a greater risk of having sleep apnea due to our airway issues. Smokers. Current smokers are nearly 3 times more prone to having sleep apnea compared to never or past smokers. Family history, as I mentioned earlier, genetics plays a role. And there's about a 40% of the variance of AHI has a genetic basis. So AHI, what that stands for is the apnea-hypopnea index. So that's something the sleep study records. So the sleep machine records how many times you stop breathing for 10 seconds or more per hour. So I'm pretty sure the diagnosis in America is the same as Australia. So anyone who stops breathing 5 times or less is considered normal. 5 to 15 times per hour is mild. 15 to 30 is moderate. And if you stop breathing 30 times or more, you've got severe sleep apnea. Anyone with allergies like nasal congestion, you're twice as more likely as well to have sleep apnea. Little bit more about race, particularly the American market. African Americans have a 20% increase in OSA severity, and their oxygen levels tend to drop more. And African American kids are 4 to 6 times more likely to have sleep apnea. Oops, sorry. I'm gonna go back. Okay, and as I mentioned earlier, there's a lot more severe sleep apnea in Asians because the genetics, the craniofacial. Speaking of craniofacial abnormalities, people with Down syndrome are very high risk of having sleep apnea because being very mid-face deficient, they have some airway issues there. I'll just sort of race through this a bit quicker because a lot of this is repeating. It's just more and more evidence because I present this this lecture mainly to dentists who like a lot of like scientific evidence behind everything. Here's a good one. 27% of men and 11% of women between ages 30 and 70 have sleep apnea. Men are 3 times more likely. And the bottom one, there's a good point. Women tend to have less severe OSA than males, with a lower AHI, shorter apneas and hypopneas, but the episodes of upper airway resistance that do not meet the criteria for apneas are more common in women. That's important to know because men and women, again, are different. So I find in particular young and middle-aged females, a lot of them come back, they get their sleep study, they don't have sleep apnea, but they have something called upper airway resistance syndrome. So they have all the same symptoms as sleep apnea, but they're not dying, but they're different because, as I mentioned earlier, the AHI score, it only records it when you stop breathing 10 seconds or less. So often these females stop breathing, but you know, they might get to 7, 8, 9 seconds and then suddenly their breathing resumes normally. So it doesn't get recorded. Potential reasons for this, obviously, males and females are different with the hormones, the weight, where they pack on weight. But a key thing that I notice in my practice is that women tend to have more TMD patients because they tend to clench and grind a lot more. So clenching and grinding, here's the secret. Okay, at the International Academy of Advanced Dentistry in Sydney, our faculty, we spent about 6 months going through every single paper there was on bruxism. And the secret is that everyone clenches and grinds their teeth in their sleep. So it's a Goldilocks thing. It's like too much is bad because you'll get all the TMD symptoms, and too little is bad too because you don't have the protective reflex. So what happens when you're sleeping is, say you stop breathing, your oxygen levels drop, you're asleep, you don't know this is happening, but your brain always knows what's going on. So one of the ways, so when we're in deep sleep in particular, our muscles relax, our air pipe actually closes and it can shut down. That causes us to stop breathing. So the best way to open up the airway is to clench the muscles around our jaw and our air pipe. So that opens back up our airway. So it's a protective reflex. So we don't, choke to death in our sleep. So women tend to do this a lot more. So they're protective reflex, whereas a lot of men, men are different to women. So what also happens during sleep is when you stop breathing and your oxygen levels drop, your brain shoots adrenaline through the body. Your heart rate goes up, your blood pressure goes up. Other things can happen. It might make you toss and turn. You might get night sweats, things like that. All of this it's obviously a whole nother topic, but all of this is related and due to sleep breathing issues. OSA and health. Obviously, if you have sleep apnea, it can't be good for your health. In particular, the heart. Your lungs, it's obviously linked to metabolic disorders like diabetes. It's really it's a vicious cycle. So what I found is, this is even also from personal experience. When I had severe sleep apnea, when I didn't know about it, you're tired all the time. And your gut, your hormones, they're all out of whack. So, and you just keep going through this cycle of putting on more and more and more weight. For example, if you don't sleep well, your ghrelin levels are up, so the hunger hormone, so you tend to eat more, but then you're also too tired to exercise because you don't sleep well. It's just a vicious cycle. So these patients tend to just pack on more and more weight. So it's actually quite hard for them to lose weight. OSAs, obviously, it can be bad for personal relationships. Like I often have patients coming in like, look, I really got to do something because I can't even sleep in the same bedroom as my partner anymore because, the snoring or the sleep apnea is so bad, or because they use the CPAP and it's too noisy. Obviously, if you have sleep apnea, you have decreased work productivity due to things like being tired, being moody, brain fog. They're all common symptoms of sleep apnea. And increase of like occupational incidents and motor vehicle accidents. It's also important to know that there's a 40 to 80% in OSA prevalence is between 40 to 80% in patients with heart disease. So the biggest effects is on the heart, as I mentioned earlier, with the increased blood pressure, heart rate, especially when you're sleeping. So your heart's not really getting rest when it's supposed to be resting. Okay, I added this slide in just a couple nights ago, actually. I thought I'd highlight this because this is very important. Here's the main issue I find with what's going on around the world. Firstly, here are the cold hard facts. Approximately 1 billion adults globally aged 30 to 69 have OSA. And of those, 425 million have moderate or severe OSA. So that's a pretty high number. And if you have moderate or severe OSA, the research shows that you are very high risk of having like a heart attack in the next 10 to 15 years if left untreated. Also, 15.5 to 22.6% of OSA patients can subjectively identify symptoms to make them even seek medical assistance. So a large majority of the population don't even know what they're looking for, so they don't know to go see a doctor about it. And it's estimated that 82% of men and 93% of women have undiagnosed OSA out there. So there's a lot of people getting untreated, which is dangerous. On the flip side, even if they do go see the doctor, unfortunately, our doctors may not even know what to do about it. Here's a survey of Australia and New Zealand dental schools, a total of 4.5 sleep hours in their whole undergrad learning. So I went to UQ, I graduated in 2009. I can tell you I had 0 hours of airway and sleep education. I did not know what an airway was. Let's talk about America. There was a survey of the 4-year medical school curriculum, including Harvard Medical School. There was only an average of less than 2 hours of sleep education, and 30% of the schools had no education. More global survey of 12 countries in Asia Pacific and North America. The average time spent on sleep education was 2.5 hours. Certain countries had no education, and more developed countries like Australia, USA, Canada had about 3 hours. So 3 hours in all the doctor's whole curriculum. So they pretty much tells us they don't know very much, or or they didn't learn anything at all. They may have forgotten already. So so this is one of the reasons why I teach health professionals to, not just educate the public, but the doctors as well. I'm actually also in the process of setting up an online course. So I'm trying to get that in also in as many different languages as I can to help hopefully spread that word. Now we've done the nitty gritty, let's talk about treatment. This is my treatment overview. My treatment was actually done by Dr. Kenneth Lee. It took 4 years all up. I actually flew, because I'm based in Brisbane, I flew an hour and a half. So it's an hour and a half flight once a month for 4 years to see him. So I've had 2 bouts of ENT surgery. One of them was by Dr. Broadhurst. He's a Harvard grad, and another one's Dr. David McIntosh. He's quite well known, I think, around the world. You guys may have heard of him. So as I mentioned, I had the home sleep studies done, 6 in total, actually. I know a lot of you guys in the Airway circle are myofunctional therapists, so you'll be happy to know I had 5 sessions of oral myology, because obviously there's research out there that shows myofunctional therapy helps, which I have a slide for later, so we'll go through that. I also did 4 years of immunotherapy treatment. So that's the allergy specialist. So I did the skin prick testing and I got the injections. With kids, they can do the oral drops under the tongue, but I think the injections seem to be more effective. Now, as far as I know, because my wife's going through it right now, the vaccines are coming from, they're being made in either France, Spain, or Canada. There's not many places in the world that actually make these vaccines. So you get tested, they order the stuff. It can take up to like 2-3 months for the stuff to arrive. So, but it's quite effective. As far as I know, success rates are over 80%. But you have to do this treatment for a good 2 to 3 years minimum to really see the results. So I used to have a block, when I had sleep apnea, I had a blocked nose like every day, but I only get a blocked nose now when I'm sick. I also see allied health professionals, in particular my osteopath, every month. Being a dentist, and being put in these awkward positions at work, we tend to have neck and back issues. So I need management for that. Now, if you really want to learn more, you want to be like Alice in Wonderland, jump down the rabbit hole. I went through functional medicine. So I had quarterly consultations. So because with having sleep apnea and other conditions, it's related to, there's a lot of conditions that are related to it. For example, so I did not just your normal blood testing, did hormone testing, Did things like obviously allergy testing. Gut testing is a big one. So people are talking about the gut-brain connection, gut-brain health. Um, Even further, I did genetic testing. So I found out that I have two genetic mutations in two genes that affect the energy cycle. So then I need to take certain supplements to work around that. So even though I've had all this treatment, I'm still not as good as I can be. I wouldn't have known if I hadn't done these genetic testings. And I think in America, you guys are really good at that because we take samples here and we send it to America to get tested. So you guys can access that a lot better. So my treatment, this is what I had done. So I had my records done in 2013. I had removable appliances, removable orthopedic appliances in the upper jaw. So I had two different appliances. That took about 10 months. I had ENT surgery in 2014. I had a septoplasty, which is straightening the nasal septum. Turbinates reduced, so the swellings in the nose that were mainly from allergies. Adenoids removed, tonsils removed. A tongue coblation, that's like a shrinking of the tongue. A modified UPPP. There's a whole slide on that later. So as a kid, it's generally a quick recovery. They might be, they might have a sore throat for like a weekend or maximum 5 days. As an adult, ENT surgery in particular, anything to do with the soft palate and tonsils is extremely painful. Some say the most painful surgery known to man, because men don't go through childbirth. So women are a lot tougher than us. For me, I was literally on a liquid diet for the first week. I introduced soft foods in the second week, and I couldn't eat normal till the third week. And as a result, I lost 6 kilos. So that's a nice side effect, weight loss. So, and then I had braces for about 3 years. Now this is a bit technical there, but I had protraction mechanics. So that's important to know. What that is it means when the teeth were being moved forward, one tooth at a time on each side. So the reason for that is because we want a bigger jaw, we want a bigger airway. We don't want to do anything that might pull teeth back or close spaces in a certain way that undoes all the previous expansion and makes our jaw smaller, because that may have a worsening of the airway, the TMJ, breathing, sleep. After treatment, I wear a nighttime appliance, not a regular retainer. So I actually wore something called a Farrar splint. I'll have a photo of it later. And then later on in 2020, I changed to a mandibular advancement splint. Pros and cons of that. You may be aware with mandibular advancement splints, there's a risk of long-term bite changes. So I've actually had that effect. So I have a bit of a slight open bite now posteriorly because of the lower jaw being held forward. What people don't know is that a mandibular advancement splint has a twin block effect. So you may know your laws of physics, Newton's third law, for every action, there's an equal and opposite reaction. So if this lower jaw is being held forward, so whether it's a twin block or a mandibular advancement splint, this is coming forward, which is great. But there's also a pullback effect on the maxilla. So it's not ideal, but otherwise, alternatively, you might have to consider surgery if you wanted this to come forward on its own and no pullback effect here. Here's my pre-treatment photos. As you can see, I had some crowding, obviously, but it wasn't that bad. So when I tell people the reason why I went through orthodontics was to improve my airway and sleep, obviously your regular dentist doctor wouldn't get it. But I'll tell you what I see here. I'm not an overweight person, but I have that, that double chin look. What that means is the jaws are actually retruded. They're pulled back. They didn't develop in the sagittal direction properly. It also means low tongue posture. So as you can see in the photo, I had low tongue posture because I was mouth breathing at the time. When you see lower anterior crowding down there, that's another sign. Again, the top jaw hasn't developed sagittally enough. So if that top jaw was further forward, you wouldn't have that lower anterior crowding. So I took CBCTs. These are just 2D slices to convert it to the OPG LATCEF PA-CEF. You can see my septum was slightly deviated. Now, the corners of the mandible, those are the gonial notches. That's a dead giveaway that there's a history of bruxism. And if you look on the OPG and the edges on the corner of the mandible, if they're jagged, it tells you it's active clenching and it's pretty bad. Even further, if you see septi in, like, if you scroll through the CBCT, you see septi in the sinuses. That's another dead giveaway. There's really bad bruxism. Obviously, on a lat ceph, you can look at things like adenoid region and the oropharyngeal airway. That's something that was never taught to me at dental school. Ceph tracings, I used the Jefferson tracing. I actually know Jefferson personally. Because it's an arcular analysis. So it's aiming for the fuller faces, fuller profiles, fuller faces, which should result in a better developed jaws, TMJ, and airway. So as you can see, for those who don't know about the ceph tracings, the arc here at the front, both my top jaw and my bottom jaw is just behind that line. So further development could have been done. So we'll compare that to my finishing records shortly. Airway analysis. So my airway was tiny. So it was so you're only good as your narrowest point. So when you breathe, air starts from the tip of the nose all the way down the airway to reach the lungs. So you got to find out where all the blockages are. That's why I had the ENT surgery to clear up the nose, the adenoids, tonsils, all that. And so this was before surgery. My minimum cross-sectional area of the oropharyngeal airway was at 54.9. And we'll compare that to the results after treatment. This is an occlusal analysis for orthodontics. Pretty much the result was, you'll see later in the photos, my bite was jacked up, so better vertical for the TMJ. Both my jaws came forward, decompressed the TMJ. C-line is the same. We call it the C-line, the cosmetic line. It's the same as, you may have heard, the Muse indicator line, where we measure the incisal edge here to the tip of the nose. That's a sign of sagittal development. Jaw opening got better. One thing I didn't mention was I had a really loud click. So every time I open and close, like, I'm eating and people can hear me from like a different room. Like, it was that bad. But after about 2 years, that actually went away. So by bringing the top jaw forward, allowed space to bring the lower jaw down and forward to decompress that TMJ, and the disc could go back into the correct spot. Doesn't always happen. In my hands, I can tell you there's only been 2 kids I haven't been able to correct a jaw click. So we're working with kids, pretty easy. With adults, is a lot harder. It's probably like 50-50, because obviously the jaw joint's been fully formed for so long. I had grade 4 tonsils. My Malin Patty was also class 4, so you'll see that in the photos shortly. Yeah. ENT surgery. So benefits of ENT surgery. I'll just rush through this. So these are just all articles that prove, that support ENT surgery for OSA. The favorable factors are to have good success for ENT surgery: if you're less than 60, if you're not obese, if you had mild to moderate sleep apnea, and if you have obstruction in the oropharyngeal area like tonsils. So I pretty much met all of these categories, except I had severe sleep apnea. Now, unlike dentistry, whereas like for us, we think success is like, 90% plus. In medicine, it's a little bit different. So I don't know if it's different in America, but in Australia, this is what they told me. So success for ENT surgery is improvement in quality of life by reducing the OSA symptoms, reducing their AHI to less than 20, or by greater than 50%, and improving their minimum oxygen level to above 90%. The modified UPPP. Now, I didn't have the classic, the traditional one where they removed the uvula, because I think research shows that there's a high chance of relapse, and also people had swallowing problems when they don't have their uvula anymore. So that's when they cut pieces of the soft tissue there and they actually stitch it up, so you still keep your uvula. So you'll see that in the photo shortly. So these are just studies saying how it, how it improves quality of life, and blood pressure is improved, and all other things. Myofunctional therapy. A lot of research out there, and still more coming about myofunctional therapy. It's all very positive. It's been shown to decrease AHI, reduce arousals, and helps improve daytime sleepiness, sleep quality, and quality of life. I think the important thing to know with myofunctional therapy is that It shouldn't be the standalone treatment for someone with OSA. And it's a very good adjunct. So like, the patient may need some other treatments, whether it's like ENT surgery, a CPAP, or mandibular advancement split, for example. And then myofunctional therapy is also good to add to that, which is why I had 5 sessions myself. And being Aussie, I'm not sure if you guys are aware of that article. People who play the didgeridoo, because there's a certain way of breathing, they call it cyclic breathing or something. So if you play the didgeridoo, it improves your muscle tone, and it's like a myofunctional exercise and reduces your risks of having sleep apnea. So yeah, I still haven't learned how to do that yet. So now this is a bit of a controversial topic for some, especially to traditional orthodontists. Adult orthopedic expansion. So I mentioned earlier, you can expand the top jaw at any age if you do it the right way. This is without surgery, by the way, so non-surgical ways of expansion. My oldest patient, I think, was 55 when she started. And I know my mentors, they got patients in their 70s that have done expansion. So these are just some studies that show that, expansion reduces the nasal resistance, increases airway volume. It improves what else? It's a safe procedure. What we do, what we teach is slow expansion, maximum 1 millimeter a month. So it's very, very slow and safe. We are against rapid expansion, even in kids, because splitting the suture has been shown to have some negative effects on the nasal septum, because as I mentioned earlier, the maxilla and nasal septum are connected. If you split that, the nasal septum can drop and can often has to go one way or the other. So it can actually become more deviated. As you can see in the bottom study there, maxillary treatment, transverse maxillary expansion in adults gives increased space in the premolar area, minimum molar tipping. If you do it too fast or too much, you can get tipping in molars or even push teeth out through bone. So it's dangerous. So there's a certain way to do it. If there's any orthodontic practitioners listening, make sure you learn from the right people on how to do it safely. There's the effects on the periodontium are clinically insignificant if you do it slowly and safely. All right, some pictures. So before and after surgery. As you can see on the left, I barely had an airway space. The tonsils were like kissing in the midline there. My Malin patty was class 4, and that was my pictures up my nose. You can see the enlarged turbinates, not much space to breathe through the nose compared to the right-hand side. The top photo there, sorry, let's drink some water. That was the stitches after surgery. And the photos down the bottom, you can see the scar tissue there where they, after the stitches came out and all the healing was done. You can see the Malin patty or Freeman classification went from a class 4 to a class 2, and you can see the tonsils are gone. So my oropharyngeal airway space is a lot bigger. The appliances I wore. So two appliances at the top there. The one on the left's called an anterior push sagittal, and then the one on the right's called a 50-50 sagittal. And then down the bottom there, that was the study models before and after expansion. So in 10 months, you can see the differences there in width in both the premolar, the molar region, and the premaxilla. The premaxilla region got pushed forward. And I'll have proof of that shortly with the x-rays. So post-treatment photos. My profile was fuller, had a wider smile. The teeth photos. I do still have the wire down in the lower anterior region. As adults, you'll see on the top left photo, there's some black triangles there. So that's one of the warnings we got to give adults, especially if there's a lot of crowding in that lower anterior region. The bone, the gum, the tissue's less forgiving. So they may end up with some black triangles, especially if they're teeth shape is very triangular. So often we do some IPR, some shaving in between, to lengthen those contacts for both for stability and to reduce those black triangles. This is post-treatment x-rays. The airway on the right-hand side, you can see the oropharyngeal area actually got bigger. And here's the proof. Firstly, the ceph tracing. So you might remember the pre-treatment ceph tracing, both my jaws were behind that arc. And after treatment, they're actually both just in front of the arc. So both jaws came forward. But you can't bring the lower jaw forward because we have an overbite, like the overbite overjet. You can't bring the lower jaw forward without bringing the upper jaw forward. So that has to be worked on first. And then we decompress that lower jaw. And the airway. So before treatment, it was at 54.9. After treatment, it was at 94.9. So it nearly doubled. Being at 94.9 is still small, actually. So I'm still not like, the airway is still not great. But considering I didn't get, discovered, I didn't get diagnosed till I was an adult, this is the best we can do. Alternative options would actually be like jaw surgery, maxillofacial surgery, but that might end up making me look like a monkey. So I didn't elect for that option. So I already feel a lot better. I pretty much live a normal life now, can play active competitive sport again. So I'm pretty happy. And here are the sleep studies. So we mentioned the AHI. This is to show that at every stage of treatment, my sleep apnea improved. So before surgery, I was at 54.1. So you'll remember that anyone above 30 has severe sleep apnea. My longest apnea was 46 seconds. So I held my breath for 46 seconds. If you told me to do that now, I don't think I could do that. So it was pretty damn bad. Minimum oxygen was at 83. So that's not good. If you're in a hospital with all those cords attached, if your oxygen drops below 90, the alarm bells go off and the nurses rush in to find out what's going on because they think it's an emergency. So below 90 is not good. If you drop down to like 70%, things like organ failure can start to happen. So just to give you an idea. So after my ENT surgery, it went from 54 to 20. So that's success, right? Because the AHI improved by more than 50% and the quality of life and all those other factors. Oxygen improved to 90. And then after orthodontics, so the expansion and the braces, it dropped down from 20.4 to 14.4. So just to show that the expansion and the protraction orthodontic treatment, increasing the airway size, actually helped with my sleep as well. And then when I wear an appliance at night, it's at 6.4. So even better. So that's just to help you guys understand that, all the steps were necessary and how each step can actually improve someone with sleep apnea. They're the appliances that I wore. So the top one there is the Farrar appliance. So it's got a ramp there to help guide that lower jaw forward in a forward position so it doesn't drop back when you're sleeping. The hole is to attract the tongue, to keep the tongue forward. So as you know, especially with oral myology, the tongue has to be in a good spot. So ideally up in the palate and forward. If it drops back or is sitting in the lower jaw, that can, block the airway. The reason for the lower 3 to 3 Essex, that's to jack open the vertical. So firstly to decompress the TMJ. Also because the lower anteriors are very sensitive. If they hit the ramp, on the top splint, it can be quite sore as well. So that's also for retention purposes and to sort of cushion those lower anterior teeth. The lower photo is digitally printed nylon, 2 millimeters thick mandibular advancement splint. That's what I wear right now. So technology these days. So no impressions anymore. Just use a scanner, take a CBCT, send it off. And the lab does the rest of the work. So last year, actually, as part of my master's, I published it. So my whole treatment journey there in the Journal of Oral Medicine and Dental Research. You can, you guys can't click that link, but you can Google it and download it if you want to read it. It's 11 pages long, quite a simple read. I think there's 25 references. It just goes into more detail about my whole treatment journey, again, showing how each part of the treatment improves sleep apnea. I mainly did that to help people, again, connect the dots, but also to make orthodontic practitioners more aware of sleep and breathing issues. Okay, that's the end of it. Hope I didn't take too long.
That was perfect, actually, considering that we started late. Wow, that was incredibly interesting. I don't know if we've ever seen a case, a personal case that's been shared by a professional where there are so many different disciplines and procedures involved. I have a question. I guess there are just a
Yep.
few others, but in terms of treatment sequencing,
Yep.
what factors played a role in determining what we're going to do first? When do we retest to see what has to be done next?
Um, so at the start, when I took the starting records, obviously a sleep study was already done, CBCT was already done. So usually it it differs for everyone, but usually if there's significant airway issues for me, like if a patient comes to me, say for example, if there's even a financial issue, I would actually tell the patient to get their health right first. And if there's blockages like adenoids, tonsils, turbinates, deviated septum, I actually tell them to get their health fixed first, so they're breathing and sleep. So off to the ENT, because obviously all these procedures and treatments take time and they're expensive. They're not cheap. To get the quickest, most immediate help, benefit, effect is ENT surgery. That's if they have those issues there. Also, regarding that, some patients, their airway issues are so bad that they can't actually wear an expander. Like they may have a strong gag reflex, or because their nose just, they can't breathe through their nose, they have to breathe through their mouth. And if we're trying to pop an appliance in their mouth and they're trying to breathe through there and eat, chew, swallow at the same time, they're going to struggle. So those patients, if you, anyone out there, if you're putting an expander, whether it's removable or fixed, the patient just can't handle it, they're not compliant. Maybe it's because you haven't sorted out the nasal airway issues first. So that I've only really been caught out in the last 10 years, probably 2 or 3 times by this. So in those situations, I actually had to stop treatment and say, hey, I can't continue until you get the airway stuff sorted. So it's usually the airway stuff that comes first. Yeah. And regarding particular to you guys, as for oral myology, oral myology is good, but I tend to refer to the oral myologist after I've done or part way through the expansion. The reason I do that is because a lot of the time I tend to see the more difficult cases, I guess, because people refer me cases. So these patients have really, really small mouths, and there's no chance that their tongue's going to fit in that roof of the mouth properly. So I get the jaw wider first, which makes your life easier. So it's much easier working together that way.
Okay, thank you very much. I think everyone is really appreciative of hearing that dual perspective, the personal and the professional experience. That was a long journey. Did you feel, if you don't mind my asking at any point, because I know we run into this with many of our patients once we've presented what some of the options are and the fact that it's not just one thing that's going to correct the problem. What kept you motivated and wanting to keep going?
Well, firstly, I think it helped because ENT surgery was the first stop. So you saw my AHI drop from 54 to 20. So I was almost a normal human. I remember the very first night in hospital when I woke up. 5 hours of sleep in that hospital bed after surgery was better than any other sleep I could remember previously before that. So I could really feel, and that's a comment I get from a lot of patients, even kids. They wake up and like, well, right now I'm congested because I'm a bit crook, but they're like, oh, I can breathe again, and like, oh, mom, I can. There's so much air, and then it's quite common for them to then suddenly, because they're breathing better, sleeping better, they're focused at school's better, they achieve personal bests in athletic performance. These are quite common things I see soon after ENT surgery. Yeah.
Got it. Can I just ask, are you able to just stop your slideshow if you don't mind,
Yep.
just so we can see you? Because
Oh,
this way
sorry.
when people watch the recording, they can see you and hear you at the same time.
Thank you so much. What a wonderful presentation, and thank you so much for hosting, Anne.
Oh,
Is that
you're
better?
welcome. I think
Not
you
yet.
just press stop on
Oh, stop
Stop
share.
sharing.
and then stop share. There you go.
Yay!
Perfect. Okay.
Thank you.
That was really great. Thank you very, very much. Do you find with your patients you provide the education about why they need to see multiple providers and they're on board, or is it a hard sell? Because we find that to be the case sometimes with our patients.
For me, it was initially. So I started doing orthodontics in 2013. So the first couple of years were a lot harder, maybe because I didn't have as much knowledge. So maybe the way I spoke, communication, the conviction wasn't quite there. Then we brought the cone beam along in 2015, and I found that really helped. The reason being, having a cone beam as part of my ortho records, and then getting a report from a specialist. So they're getting me telling them that you have a problem, and then so does the specialist. And then the proof is there in the x-ray, in the report, that you have all these issues. And then, yeah, so and then plus often in an examination, say, I'm looking at patients' noses, looking in their mouths, talking about things that other dental professionals never talk about, asking questions like, how does your child, how's their breathing, their sleep, all those kind of things. So the parents straight away know that you're different, and then more, and then I guess that helps build that trust.
Right. Okay, that makes sense. Well, I know you have your day ahead of you still. We're wrapping up our night, but I want to thank you very, very much. I appreciate it. I have one last question. Someone just threw it in the chat. Is that all right if I just
tongue tie.
Yes, do you see that? How often? Yeah, you see
Great question. It's that's also one of the things I check as part of the assessment. So I'm not sure how it is in America, but in Australia, there's been a lot of lawsuits lately, because as part of my faculty, actually, where we know all the lawsuits in the dental industry that are happening at all times. So because like Dr. Mahony, Dr. Lee are often asked to defend these dentists. So the situation now in Australia is you need 2 different health professionals to diagnose the tongue tie for that procedure to go ahead without getting in trouble. So when I assess a tongue tie, I look for functional issues like, obviously swallowing, speaking, chewing. But a good way to test is so as part of an orthodontic assessment, you get the patient to do max opening, you measure that, and then you get them to do max opening with the tongue to the tip of, exactly what you're doing right now. So if that is less than half, that's a functional deficit. So that's one of the things I do in my assessment. And let's talk about kids in particular with tongue ties. We tend to find that they, because their tongue's being held down, they tend to often result in class 3s. You might see underbites, they tend to be like that. So in fact, we were having this chat just a couple of weeks ago, at our faculty meeting, where we tend to see a lot more class 3s these days, whereas years before, because obviously Dr. Lee, Dr. Mahony have been practicing for 30 plus years, they tend to see a lot more class 2s coming in, but now we're seeing more and more class 3s, maybe because of, whether it's large tonsils, tongue ties. These are 2 things that have been shown to be associated with class 3. And an important thing to keep in mind, class 3s in a child under the age of about 9 or 10 is a functional issue. It's not a genetic issue, because puberty and the growth spurt has not kicked in. So babies are naturally born at class 2. And over time, when growth happens, puberty, growth spurt, the lower jaw starts to catch up. And then eventually, hopefully, get to a class 1 occlusion. So if you see a child like this already, it's usually a functional problem. And the first thing I check is breathing, which will be like the tonsils, tongue tie, things like that.
That's really interesting. Wow. Thank you for sharing that.
And and the ENTs I work with, I'm a neat and tidy person. I don't like doing tongue ties. So I send that to the ENT as well. So they do it all in one go while the patient's asleep.
Do you find that's common in a lot of the patients that you're treating, that you're seeing restricted tongues? Like what percent, if you had to throw out a percentage, what would you say?
A restricted tongue movement, I'd say, is common, maybe even around half, but a true tongue tie, not as common. But again, if I see it, then that second opinion will be with the ENT. And then if the ENT agrees, then they'll just snip it for the patient. So not sure of an exact number, but I wouldn't say it's rare, but I would pretty much, let's say in my office, every week I would see a handful of patients, yes, with a tongue tie. Yeah, a real obvious one is where it's like that heart shape, like it's really being tied down, and you see that, like, yeah. Oh, sorry.
Okay.
Yeah.
Thank you. Anyone else before we wrap up want to ask?
And
Yeah.
thank you. Thank you so much. This has been wonderful. Thank you for hosting Dr. Robert Lynn. We know how busy you are. We really, really appreciate you taking the time to come talk to Airway Circle. This is going to be posted in our membership. It did not go live, but I'm going to take a portion of this to share with everybody that follows us. So thank you so much. You guys were incredible. Next week, does anybody know who we have next week?
Next week, we're having Dr. John Karodkin talking to us about MARP, MSC, SFOT, and the constricted upper airway patients. So
that is going to be fantastic. Please join us. We love you guys. Thank you so much. Have a wonderful night. And Dr. Robert Lynn, have a wonderful day.
Yes,
Thank
Dr.
you.
Lynn, quick question. You mentioned our references. Was that in the slide? Do you have a list of references?
I can send it to you guys. Yeah,
Are you
from
able
Yeah,
to?
that'd be great.
Yeah,
That would
sure.
be great if you can. Thank you so much. I'm sure people would want to reference this. So thanks again. Thank you, everybody.
Okay.
We'll see you next week. Have a great day. Good night.
Bye-bye. Thank you.